Today's topic that I have chosen is a very important topic for the medical students because they find it a lot of difficulties in doing the examination of the joints and especially the knee. So let us see how to examine the knee. Many of the books have written, many of the authors have written, but I am going to demonstrate you how to examine the knee properly in a systematic manner. So the symptoms are commonly the pain, swelling, deformity is the usual symptom for any joint. There are some special symptoms such as locking and giving way sensation. There can be peptus or the clicks in the knee as well. So setting the stage for examination, introduction is important. Introduce yourself and tell to the patient what you are going to do. Make sure that you are examining the patient in privacy and if needed, should have a chaperone with you. Sanitize your hands and expose the joint to be examined. The international norm says it should be one joint above and one joint below. In certain circumstances, especially in examination, if the patient or the simulator is a lady, it is very difficult to expose that much. So, in those scenarios, you must tell to the examiner that I would have liked to expose one joint above and one joint below, but in these circumstances, keeping in mind the modesty of the patient, I am exposing a little less than what is required. There is some protocol for the examination that has to be followed. There are certain steps of examination. It is look, feel, move, measure. Means look means inspection, feel is palpation, movement, measurement, followed by neurovascular examination and special tests. The order has to be maintained. Examination should preferably be done while patient is standing. Should be done from all sides, front, side, and from back. An examination of one joint above and one joint below is also mandatory. It is to be observed in all lower limb joint examinations and then ask the patient to lie down supine on the bed and go for the further examination. Certain headings are very important for every medical student to remember, and these are the followings. Attitude of the limb is to be described, and then flex the knee 90 degrees and assess for the sag sign and Galeazzi sign. Swelling is to be described, and when you are describing, you must understand that you have to describe whether it is diffuse or localized. A diffuse swelling on the sides of the parapatellar area is an evidence of intra-articular effusion or hemarthrosis, whereas the bursal swellings are usually extra-articular and they are usually localized. It can be prepatellar and infrapatellar. We come to that again. In popliteal fossa, there is a swelling which is called Baker's cyst, and there can be swelling on the sides in case of injury to the collateral ligaments, and there can be swelling in the medial joint line is meniscal cyst or can be loose bodies. Deformity is to be ascertained, and deformity usually is the varus or valgus and sometimes can be fixed flexion deformity. Skin around the knee is to be assessed for the previous scars, sinuses, signs of inflammation, and in some fresh cases, bruises and ecchymosis, and sometimes in the case of malignancy, for the signs of engorged veins. Wasting of the muscles is to be assessed, and limb length discrepancy is to be assessed. So remember those headings. It is very important. Inspection from the front, you will be assessing all the headings that we have just discussed. Attitude, shape of the knee, it means the patellar prominence, the position of patella. Patella can be placed higher or lower than usual, and if it is lower, it is called patella basa, and if higher than the usual, it is called patella alta. Swelling again, and it is parapatellar depressions for the knee effusion, suprapatellar pouch for the tense effusion, or sometimes it can be a synovial proliferation. Joint line swellings for the loose bodies or meniscal cysts, swelling over patella or prepatellar bursitis, and swelling below patella is infrapatellar bursitis, and a horseshoe shaped swelling suggests that effusion is very tense. Deformity, whether it is knock knee or bow leg deformity, muscle wasting, and limb length discrepancy can be assessed when the patient is standing by the level of the shoulders as well as the level of ASIS. The side which is shorter, ASIS and shoulder both will be found lower than the normal side. From the side, one can assess the fixed flexion deformity, swelling, bruises, ecchymosis over the lateral collateral ligament. And if you see from the medial side, you can see all these findings for the medial collateral. From the back, apical foci is in full view, and you will be seeing for the Baker cyst. And once you find the Baker cyst, you must confirm whether it is pulsatile. A pulsatile swelling is not Baker cyst, is an aneurysm. The gait is to be assessed. Ask the patient to walk 4 to 5 steps away from you and again towards you. Usually, in the case of the pain, is an antalgic gait. Antalgic means anti-algae. Anti-algae means against pain. In this form of the gait, the stance phase of the gait is abnormally shortened. Patient does it to reduce the pain. And then ask the patient to lie down and then go for the inspection on all the headings that we have just described. This is the headings that we will be describing. The headings are the inspection. First, you look for when the patient's knee is bent. And then you look for two signs, Galeazzi sign and sag sign. Then straighten it, and then you have to look for, and the headings are attitude, swelling, deformity, skin changes, muscle wasting, and lastly, limb length discrepancy. So there are the 6 one. Never forget not to do even one. After understanding all the headings, this is the way we will be doing sag sign. We can see by flexing the knee 90 degree, the tibia goes backwards because there is a tear of posterior cruciate ligament. It is the function of the posterior cruciate ligament to not allow the tibia translate backward. You can see the clinical sign. This is the tibial tuberosity has gone back, and moreover, the anterior side, which should be convex, has become concave. So by flexing, this is the one method to elicit the sag sign. There is a second method also. Flex the hip and knee 90 degree and catch hold of the leg around the ankle and see there is a sag sign. Galeazzi sign is see the top of the knee. The top of the knee, one of them is lower, it means that limb is short. And then this is the way we'll be looking for sag sign and Galeazzi sign in a patient. And then you have to look for the sag sign. How to look for the sag sign? Not like this. This is not looking for the sag sign. You bend and the eye should be in level of the tibial tuberosity, and then you say both tibial tuberosity are at the same level, and so there is no sag sign. Also you can say this, can you see the convexity? Supposing this is the affected side, this convexity, both are present. Otherwise one will be concave when the tibia goes downwards. And the second sign that you see is Galeazzi side. You look for the top of the knee. Both are at the same level. If one is down, it means that particular limb is short. So you have seen how to start it, sag sign and Galeazzi sign. So this is the technique of looking at the sag sign and Galeazzi sign. For the effusion, you will be looking at the parapatellar gutter or depression, and you can see this is the depression, and this means if it is full, this knee is there is effusion, is intra-articular. And see again, there is gutter is present, and in this knee full. There can be bursa in the knee, that has to be remembered. Suprapatellar bursa communicates with the knee joint. Prepatellar bursa is there over the patella, and infrapatellar bursa below the patella, that has to be remembered. The pes serenus is not so commonly seen. The prepatellar bursa, it happens this way by working. A housemaid works like this. Nowadays nobody working like this, but it can happen, and that's why it is called housemaid's knee. Whereas the clergyman's, they don't bend too much, and so it is happening with the clergyman's, and this is called the infrapatellar bursitis. Can be large loose bodies in the joint present as a swelling on the medial side, and can be a small meniscal cyst on the medial side can be seen. Now, what are the deformities and how to look at them? What are the deformities in the knee that we should know and detect? One is the fixed flexor deformity, genu-varus deformity, and genu-valgus deformity. Once you say the knee is extended, you have ruled out the fixed flexural deformity in that particular knee. Genu-varus and genu-valgus deformity will be done later. So this is the deformity that you should look, the technique I have shown you, and how to describe attitude swelling and deformity. The knee is extended, and it means there is no fixed flexural deformity in this knee. Let us look for the swelling. What are the swelling possible that you must know? There are usually two types of the swelling that you have to detect in the knee. One is the intra-articular swelling, another is the extra-articular swelling. The intra-articular swelling you have to know by looking at the parapatellar depression. And if the parapatellar depression is not full, and so there is no effusion in the knee. Also there is no swelling in the suprapatellar area which is communicating with the knee. Still it is intra-articular swelling. For the extra-articular swelling, usually it is bursal swelling. There are most commonly two types of the bursal swelling. One is the prepatellar, which is over the patella, and one is infrapatellar, which is called infrapatellar swelling. In common colloquial terms, the infrapatellar swelling is called a clergyman's swelling, and the prepatellar swelling is called a housemaid swelling or housemaid's bursitis. So there are two bursitis you can describe. One is the housemaid bursitis, which is prepatellar bursitis, and another is the clergyman's bursitis, which is infrapatellar bursitis. In the intra-articular swelling, there are two types of the swelling again there.
One could be the effusion and another can be the synovial proliferation. And it will be done in due course of the time when we come to the palpation. Let us look at the deformity. How to look at the deformity? Close both of the limbs, and then if the medial malleus are touching and the condyles of the femur are also touching at the same time, it means there is no genuvarus or genuvalgus deformity. These two are the most common deformity that we find in the examination of the knee. Now, how to detect if there is a genuvarus or genuvalgus deformity? And there could be a condition when both the malleoli are touching and there is a space between the two condyles of the femur. What is this condition called? It's called genuvarus deformity. So both malleoli are touching and there is a space between the two condyles. This condition is called genuvarus deformity. Where the other deformity is when both condyles are touching and there is a space between the two malleoli, then it is called genuvalgus deformity. There can be a question like this. In a given patient, there is a distance between the two malleoli which is 10 centimeter and the distance between the two condyles is 20 centimeter. What is the condition called?
Condition is called genuvarus deformity. How to look at the vesting of the muscles, what is the technique of
Look at the bulk of the quadriceps and you can say there is no quadriceps vesting, both bulks are the same.
So this is how it should be done, and then how to look at the skin changes.
When we talk of the skin changes, there are several ways of description of it depending upon what condition we are dealing with. Say for example, we are dealing with a case of the flesh injury. There, we will be looking in the skin condition, looking for signs of abrasions and ecchymosis. Or maybe if there is an wound, to describe it. The same skin changes in the condition of the inflammatory arthritis, say for example septic arthritis, we will be looking for the signs of inflammation in the category of the skin changes. Category remains the same. Red skin, hot skin, shining one, they are all signs of inflammation. The same skin changes will be looked in an old case where multiple operations have been performed and there are some history of the infection present. We will be looking for signs of previous surgical scars. We will be looking for the signs of sinuses. And the same skin changes when we are looking for, in the case of the tumor, we will be looking for signs of engorged veins, a stretched skin or shiny skin. These are under the heading of skin changes only.
So after looking for the skin changes, then see this, don't forget to look swelling in the popliteal fossa. And if there is a swelling, it is usually called Baker cyst. One must remember if there is a swelling there in popliteal fossa, which can be Baker cyst, but it must be confirmed that it is not pulsatile. So how to look at it?
Look for any swelling in the popliteal fossa. Can you turn it up? So ask the patient to be prone, considering the right side is the pathological one. You can see it. There is no swelling in the popliteal fossa. Usually the swelling, when it comes in the old days in the association with the osteoarthritis, and when it is there, it is called Baker cyst, or the full name is Morant-Baker cyst. And when you find there is a swelling there in the popliteal fossa, you must ascertain that this is not pulsatile. A pulsatile swelling is not a Mohren-Becker cyst, it is a popliteal aneurysm.
After looking at the popliteal area, we will go for the limb length discrepancy.
Close the both limb together so that your visualization becomes more accurate, and then you say tip of the both malleoli are at the same level, and so there is no limb length discrepancy in this particular patient. But had there been a limb length discrepancy, considering that the right side, say for example, is the pathological one, then I would have gone for the segmental shortening. And that I would have looked by looking at the level of superior pole of the patella. This medial malleus is up, and in a condition where the superior pole of the patella is also up, it means shortening is in the femur. There may be a condition when superior pole of the patella is at the same level, but the medial malleus is up, it means shortening is in the tibia. And if you determine that the shortening is in the femur, must remember that you have to draw a Brious triangle to determine shortening is supratrochanteric or infratrochanteric.
So these are the techniques how to do a proper inspection in a particular simulator or a patient. We'll come to the palpation, and the headings are very clear. Temperature has to be taken first, and then tenderness is to be elicited on all these parts: tibial tuberosity, tibial condyles and femoral condyles, median and lateral joint lines, median and lateral collateral ligaments, quadriceps tendon, suprapatellar bursa, whole of patella, patellar tendon, and feeling under the edge of the patella sometimes is needed in the case of osteoarthritis, and lower end of the femur and upper end of the tibia is to be palpated for tenderness. And then we have to ascertain the swelling is a conformation that we have seen on the inspection, the skin around the knee, and then scars and sinuses has to be described in details. Muscle wasting is to be ascertained, and the limb length discrepancy is to be confirmed. And lastly, palpate for the evidence of crepitus in the joint by moving the knee through flexion and extension. Look for clicks and the thuds. It means that there is a possible meniscal damage, or there may be presence of loose bodies in the joint. And also palpate for evidence of any bone irregularities or the thickening of the bone. Is usually lower end of the femur and upper end of the tibia and fibula. And then in a certain cases where there is an infection, lymph node enlargement is to be ascertained in inguinal region. So what is the best way to position yourself so that you can palpate the knee for tenderness? And usual advice is you can sit on the bed or you can sit on the couch facing the patient and the knee, and then start looking for tenderness. You will be going for the technique of doing for the tenderness, how to do it.
For the tenderness, there are several ways you can adopt, but many of the authors are of the view to flex the knee so that you can have the access of all these structures. So I have flexed it roughly 20 degrees, and then I am starting my palpation for the tenderness. I am starting from the tibial tuberosity. My both thumbs are on the tibial tuberosity, so there is no tenderness over the tibial tuberosity. And remember, the tibial tuberosity becomes tender is one disease when the boy is still growing, and that condition is called Osgood-Schlatter's disease. And then I am going up and away, and can you see my thumbs are feeling the bone. This bone by the side of the tibial tuberosity has to be tibial condyles, can be nothing else. So you can see it is a tibial condyle. There is no bone irregularity, neither there is any tenderness. Now see this, I am pushing it, my nails, and it cannot push it. But I go a little up and now I can push it. Can you show it very nicely, pushing it? So I can push it. What is this? This is the joint line which yields. So joint line, I am over it, and then over the course of the joint line, this is the joint line. Here also this is joint line. So over the course of the joint line, I feel until there is no tenderness over the joint line. Just above the joint line, if I go again, I am feeling the resistance of the bone, and this bone is femoral condyles. And I will say there is no tenderness over the medial and the lateral femoral condyles. I am going on the medial side. On the middle part of the medial side, there is the attachment of the medial collateral ligament. So I will try to feel the medial collateral ligament from the tibial attachment to the femoral attachment until there is no tenderness over the course of the medial collateral ligament. Head of fibula, you know, the head of the fibula gets attachment of, or the medial collateral ligament is attached over the head of the fibula. So I will first palpate the head and neck of the fibula and say there is no tenderness over the head and the neck of the fibula, and then from the head of the fibula I will keep on palpating till the femoral condyle in the course of the lateral collateral ligament and say there is no tenderness in the course of lateral collateral ligament. And then I will go up and then I will feel for the quadriceps, and there is no tenderness in the quadriceps, there is no tenderness in the quadriceps tendon, and there is no tenderness in the suprapatellar bursa. Now whole of the patella is palpable, so there is no tenderness in the superior pole of the patella, neither there is tenderness in the medial and lateral border of the patella, and neither there is tenderness in the inferior pole of the patella, and there is no tenderness in the anterior surface of the patella. And then I will come back to the tibial tuberosity again, telling there is no tenderness in the patellar tendon. I am palpating for the upper part of the tibia for any tenderness. There is no tenderness in the upper part of the tibia, and there is no tenderness in the lower part of the femur as well.
So this is how we palpate for tenderness, the technique that one should follow. And then there is another swelling that is called synovial swelling. Feeling for synovial swelling has got two techniques. One is try to lift the patella, and if the synovium is thickened, your fingers will slip off the edges. You cannot lift the patella. And the second one is feeling the synovial proliferation at the suprapatellar bursa, which is a better way of doing it. Go for the synovial membrane palpation in the suprapatellar pouch or suprapatellar bursa. In this region, synovium reflects onto itself, and hence synovial hypertrophy is best felt or palpated here, and it extends 3 to 4 finger breadths above the superior pole of the patella. Start the palpation from superior border of the patella, palpate the suprapatellar area moving in a proximal direction. In the case of the synovial proliferation or hypertrophy, it will be felt as a spongy structure, and it can be rolled underneath the palpating finger where it is reflecting onto itself. And the feeling of this is called dough. The second one we have just described, try to lift patella. So we'll see the technique of doing it. Question is how to differentiate between synovial proliferation and knee effusion.
Differentiation, it has got two methods. I will describe both of them. One method I am describing that is written in applet. If there is synovial proliferation all around the patella, but the patella is visible, it won't be over the patella. You try to catch hold of the patella, hold it and pull it. If you try to hold it, patella will slip because there is synovium there. It is not a subcutaneous tissue. So if there is all around, there is swelling, try to hold the patella and catch hold of it and pull it, your hands will slip. This is one test. The second test is you have to feel for the synovial proliferation in the suprapatellar bursa, where there is more space and it proliferates more, and usually there is more swelling seen. How will you feel? We all know that the suprapatellar bursa extends 3 or 4 finger breadths superior to the superior pole of the patella, and then it inverts onto itself and then goes back. At that place, it is easy to feel, but in the feel that you get by putting your fingers over the synovial proliferation, the feel is
Dough. Feeling of a dough is proliferation of synovial membrane.
and it ends superior border of the suprapatellar bursa, which means we are talking of the synovial proliferation. And remember one more, if there is a synovial proliferation and hardly any effusion, patellar test is negative.
So having done the palpation for the synovial membrane, we have to palpate the patella in details. So there are certain tenderness in the patella to be elicited. It's not very regularly done, but one should know it. Pre-patellar tenderness. A retropatellar tenderness means behind the patella on the medial and lateral aspect, and retropatellar grating found in patellofemoral arthritis. It is done by patella grinding tests. And then the gap in the continuity of the quadriceps mechanism, because quadriceps mechanism extends from the quadriceps up to the patellar tendon. So attachment of the quadriceps to patella is to be looked. Patella itself is a part of quadriceps mechanism. The patellar ligament and tibial tuberosity also, if it is avulsed, the quadriceps mechanism is disturbed. This is how you feel under the edge of the patella by pushing your finger from the medial side and from the lateral side, and then testing for the patellofemoral tenderness. You can move the patella and patient will feel pain in the patellofemoral compartment. That is the tenderness, you can see. How to predict the probability of dislocation of patella? Can we predict it? Yes, it is possible to some extent by assessing the Q angle. The Q angle is the angle formed by a line drawn from ASIS to the mid patella, and another line is drawn from the mid patella to the tibial tubercle with the knee in full extension. Average Q angle in males is 14 degree, and in the females it is 17 degree. An increased Q angle is a risk factor for patellar subluxation. This is how it is drawn. So one line from ASIS to the midpoint of the patella, and then another line from midpoint of the patella to the tibial tubercle, and it creates an angle. They are not in one line, and this angle is called Q angle. Habitual dislocation of the patella. There is a difference between a recurrent dislocation and habitual dislocation. Recurrent dislocations may occur many times, but habitual dislocation will occur each time the patient flexes the knee. This is how we will be looking at. If the knee is flexed, watch, the patella is dislocated laterally. Flexion of the knee and patella dislocates laterally. Each time it is happening. This is called habitual dislocation. Let us go to the quantifying the genu varus and valgus deformity. It is quantified as, in the case of genu varus deformity, oppose both malleoli and see the distance between the both condyles. So intercondylar distance is to be taken into account. Whereas in the case of genu valgus deformity, let both condyles opposed and take intermalleolar distance either in centimeters or many doctors do it in the finger breadths. How many finger breadths? There is a distance between malleoli or two condyles. For the muscle wasting, you have to palpate the muscle wasting, determine its volume. The mass is usually bilaterally symmetrical. If there is a reduced size of the mass, means that that muscle is atrophied, and also it is usually associated with some degree of hypotonicity. Typical feeling of the muscle tone on palpation is one of resilience. Fibrillations and fasciculations are present only in the early stage during which muscles are undergoing atrophic changes. Now we will be doing to confirm the muscle wasting as well as shortening. With the technique of doing it, it is being demonstrated.
For the muscle wasting, we'll put our fingers and say there is no muscle wasting in the quadriceps. And then for the shortening, we'll be putting our fingers over the medial malleolar tip and we'll say they are at the same level, and so there is no shortening in this particular patient. So there is no limb length.
Palpation of the popliteal fossa, already discussed on inspection. If there is a lump, you have to ascertain whether it is pulsatile or not. The second portion is, can it be emptied into the joints? The movement is to be taken on both sides and in two forms, active and passive, and is usually a hinge joint, so only extension and flexions is possible, and you have to measure in the degrees from one starting point to the end point, and it has to be recorded in a tabular form, showing movements on the right and the left side in each direction. The active extension, roughly tested by examiner, slipping a hand under each knee and then asking the patient to force the knee into the surface of the couch. It is usually easy to feel whether the hands are trapped equally strong on both sides. It means extension is there. There is another way of doing is you have to ask the patient to sit on the edge of the couch with the legs hanging over the side and then ask the patient to extend each knee as far as possible and measure the degrees. Passive extension is tested by the examiner simply by holding both legs from ankles, lifting them off the couch. The knee should straighten fully, and sometimes even a few degrees of hyperextension can be seen, and it should be symmetrically on sides. Passive and active flexion is to be noted. Normally, the heel can be pulled up to close to the buttock, while the knee moving through a range of roughly 0 to 150 be. And sometimes the heel to buttock distance is compared also to ascertain how much is the limitation. Of course, degree of the movement far better to notice. There are some authors who are advising for the internal and external rotation of the tibia over the femoral condyles. Usually it is about 10 degrees. The measurement is to be taken the apparent length from G-sternum to the medial malleoli on each side when the patient is supine and both limbs are parallel to each other. The true length, before taking the true length, there are some criteria which must be fulfilled. Pelvis must be square and both limbs must be placed in a similar position. The length of the limb is to be taken from the ASIS to the medial malleoli on both sides. And once you have taken the whole length, go for the segmental length. Either can be femoral or the tibial. The femoral length is from ASIS to the medial joint line, and the tibial length is from medial joint line to the medial malleolus. Also, in the measurement segment, when there is a muscle wasting, take the measurement of the girth of the muscles. And for the swelling also, taking the measurement of the girth of the swelling is usually prescribed. We will see how to mark some of the bony points for the measurement. And there should be no confusion about the scientific way of marking a bony point. Let us see it.
How to mark a bony point for the measurement purposes. So I'm demonstrating how to mark the bony point of the medial malleolus. Now I'm trying to dip my fingernails. I can dip it or not. It is dipping very nicely. Is there any bony resistance? No bony resistance. Now, still I cannot dip my fingers. Still there is no bony resistance. I can dip my nails. Still there is no bony resistance. Can you see it? And now I have found the first bony resistance while going towards the medial malleolus. I keep it pressed for 15 seconds or so, and you will see I have already marked it. I will put a marker dot there or a small line there. That is how you discover the bony points.
So this is how you do. From below, you go toward the medial malleolus to find the tip, and the technique has been shown. How to mark the medial joint line, the technique is being demonstrated. Now I am going to demonstrate you how to mark the medial joint line.
Flex the knee first. In extended position, difficult. So I am flexing it. See the tibial tuberosity, this is tibial condyle. And then I am following the tibial condyle. I cannot dip my finger here. I cannot dip my finger, still bone, still there is bone, and suddenly it is yielding. This yielding is because it is the junction between the tibial and the femoral condyle. This is the joint line. And then I will mark it. This is the mark. Easy. Already marked there by my fingernails. And this is the mark.
If you keep your fingernails pressed a little for 15 seconds or so, it's already marked, put the marker there. And how to mark the ASIS, that technique is being demonstrated here.
So ASIS, I am marking the ASIS. Where is the ASIS? How to mark it? You know, inguinal ligament is from the pubic tubercle to the ASIS. I am following the inguinal ligament. Correct? I am following it. So I am dipping my nails and it is dipping. There is no resistance I am finding. The first resistance that I will find will be the ASIS. Now I have found the resistance. This is the first resistance that I found in the course of inguinal ligament laterally while going towards ASIS. I keep it pressed for some time and then I have marked it.
we have come to the end of part one. Thank you very much. Thanks a lot. Go to the video a few times to have the proper skill to develop and keep on doing on the patients. For any queries and comments, you are most welcome and on this mail. Thank you very much. Thank you.